This session today is a really exciting session. I think it's about reframing how we consider obesity. If I think about my career and how people's opinions have changed around the concept of obesity, it has been pretty remarkable, and we're at a phase in history, I think, where it's really important that we all get on the same page, that make sure that we're talking about the same thing, and we put forward a united face to the general public and to the profession so that we can really move forward for our patients. Francesco Rubino is my co-chair today. You'll all be very familiar with Francesco. He's the Professor of Surgery at King's College in London and has been an absolute pioneer in obesity research and in advocacy for people living with obesity. So Francesco has been leading a process through the Lancet that is helping to achieve that aim, and we're going to go through a series of speakers today that will help describe what we've been doing, but then leaving time at the end for a really good panel discussion with some really amazing experts in the field of obesity. So I hope this is a really enlightening session for you all.
Yes, thank you. I don't want to take the time of the next speaker, so just we can move quickly. But I want to only emphasize, first of all, thanking IFSO and the organizers, yourself and all the organizers of this meeting for hosting this session and for giving us the plenary platform. I think, and I hope you will agree that this is an important topic, and I hope we can give you some good information. Importantly, this Lancet Commission has not been published yet, so we're not able to disclose all the details of what's coming up, but we're certainly able to share with you some of the key concepts, and you will see how this could be substantial, important for practice and policy.
Fantastic. So we'll start with our first speaker now, Associate Professor Priya Sumithran. Priya is a physician who specialises in care of people living with obesity and also a basic and clinical researcher, and has been on the commission. Priya works here in Melbourne, luckily for me, at my hospital, the Alfred. So over to you, Priya. Thank you.
Thanks. Thank you, Wendy and Francesco, for the introduction, and it's really an honour to kick off this session today. So I'll be talking about the aims and the methods of the Commission. Here are my disclosures. And I'll start first with why we need a commission on clinical obesity. I won't go too much into it because the other speakers will cover a lot of this, but I think that to give you a background, it's safe to say that our current approach to obesity is not effective, and compared to other chronic diseases, obesity is far less likely to be approached effectively. So not only does the prevalence continue to rise, but for people that already have obesity, they really have very limited access to evidence-based care, and often treatment for obesity is only covered if the person with obesity has another disease, for example. We don't have good criteria with which to prioritise treatment, and even within the healthcare system, we really treat obesity very inequitably compared to other chronic diseases. So I think a good example of this comes from the recent GLP-1 shortage, where, for example, the attitude from regulators, professional bodies, even companies that make obesity medications were putting out statements saying that treatment should be reserved for people with diabetes and denied to people with obesity, regardless of the impact of the obesity on that person. And that highlights some of the widespread bias and discrimination and stigma of obesity, but I think really it indicates that obesity isn't viewed in the same way that other chronic diseases are, and perhaps that's because it's framed currently as a risk factor rather than an entity that causes ill health. And again, I won't cover this in detail because you will hear about this from some of the other speakers, but in brief terms, generally when we think about diseases, they are characterised by pathophysiology that leads to dysfunction of one or more organ systems that leads to an illness that creates signs and symptoms and clinical manifestations that can be used to make a diagnosis. Whereas if we look at obesity, it's defined as a body mass index above 30 and fat accumulation that can present a risk to health. But body mass index, although it's a population measure of health risk, but doesn't tell us about the health of the individual. And the risk to health implies that, there are people who don't currently have any health problems and may never have health problems. There are people who will be at risk of health problems, but in fact there are people who already have ill health that has materialized as a result of not just the diseases that obesity is a risk factor for, but of the excess adiposity itself. And that can be identified by signs and symptoms. And that entity really hasn't been previously defined, that illness due to obesity itself. And so that was what the aim of the Commission was to define that clinical obesity and identify criteria for its diagnosis that reflect the illness that's related to the adiposity itself. So the overarching aim of this was to inform clinical decision-making, inform policy, and to facilitate identification of priorities for clinical interventions and public health strategies to address obesity. So this was a partnership between the Lancet Diabetes and Endocrinology and King's Health Partners, which is an academic partnership across hospitals affiliated with King's College London, which provided logistical support. There was a chair, which was Francesco Rubino. There was a steering committee of 8 people, and then there were commissioners, 58, who were selected through a collaboration between the chair and the steering committee and the journal editors. And they were selected aiming to achieve a balanced representation of relevant disciplines, people with lived experience across different global regions. Here you can see the commissioners, and they represent many, many specialties, including obesity medicine, cardiovascular medicine, internal medicine, endocrinology, metabolic bariatric surgery, pediatrics, nutrition, psychology, primary care, basic science, public health, people with lived experience. And so all of the invited commissioners were asked to provide full disclosure of potential conflicts of interests before approval. And the chair, the steering committee, all of the commissioners didn't receive any payment for participation in the commission. Here you can just see a geographical representation, if you keep your eye on the red markers, of where the commissioners came from. And so how we went about it is that the steering committee provided general oversight and scientific direction, but then there were a number of subcommittees formed of around 5 to 10 commissioners each that were coordinating various aspects of the work. Here you can see the names of the subcommittees according to our expertise and volunteering. We had monthly 2-hour whole group meetings between June 2022 and December last year, which I think on behalf of Wendy and John and Louise, I can say were at a really abominable time for people in the Australian Eastern time zone. And then we had offline activities as well in between these monthly meetings. So then we had this initial phase of prior to the Delphi questionnaires, where evidence on various topics was summarised by either individual commissioners, subgroups, or occasionally guest experts, which came and presented to us, the whole group, during the meetings. And the purpose of this phase was really to capture our initial views on a range of topics, find areas of agreement and disagreement, assess the evidence, and particularly to define a suitable model for how we would define a disease of obesity, and also agree on principles for how we would select diagnostic criteria. And then those results were used by the subcommittee in charge of creating the Delphi questionnaires to come up with a set of statements that reflected that evidence and tried to capture the consensus as best as possible. We then had this consensus development phase of 3 rounds where we had questionnaires that were administered and collated by a non-voting moderator, so that the responses of each individual commissioner were confidential and known only to the moderator. For the first 2 rounds, people who didn't agree with the statements were invited to state their reason, propose amendments to the wording, and then here you can see the degree of consensus and how we graded it. So after the second round of Delphi, statements that either achieved unanimous or near unanimous consensus were considered to be approved and not voted on again. And then a third round was used to see if it was possible to increase the support for statements with a lower level of consensus. And then the final document was circulated and approved by all commissioners. Thereafter, that document with just the conclusions and the diagnostic criteria that had been developed through the consensus process was submitted to relevant patient organisations and scientific professional societies for consideration of endorsement just of those definitions and diagnostic criteria. And the feedback from those groups could be used to improve the way that we presented our process and our findings in the report, but couldn't change the conclusions that we came to because they were developed through this consensus process. Then the report was prepared, outlined by the steering group, drafted by the writing subcommittee, and then other subcommittees wrote various chapters of it. It's been reviewed and all authors have had input into it, and it's been sent for peer review. I think I can say it's in late stages of that review process at the moment, so we have not launched yet, but hopefully it won't be too long away. I'll say keep your eyes out, but not yet launched. That's where I'll end.
Thank you very much, Priya. This is just a short overview of a process that has lasted more than 2 years, and it's very complex. And I want to take the opportunity to thank every and each of these commissioners. You've seen those names, and I'll do it again, for their incredible work over a long period of time. Next to speak more about this commission is Wendy Brown. She is professor of surgery here at Monash University in Melbourne. She's the host of everything here, and I'd like to ask her to talk about why obesity as a disease is a controversial idea.
Thank you very much, Francesco, and thank you very much for including me in the commission process. It was very enlightening for me, and I learnt a lot, but I did also struggle with the 1 a.m. meetings at times. So today I'm just going to talk briefly about obesity as a disease and why it remains a controversial idea. These are my potential disclosures. If we think about the idea of a disease, as Priya's already outlined, most dictionary definitions will say that it's an abnormal condition that affects the structure or function of part or all of the body and is usually associated with specific symptoms and signs. And this is something that the NIH has agreed on. So if you take an etiological factor, that will then change cell physiology, that in turn changes tissue function changes organ function, and that changes bodily function. And so that process is where you go from normal through to disease. And in basic terms, this is what a disease is. So if we pull apart the definition and consider the situation of obesity, is it an abnormal condition? Is this something that affects people in an abnormal way? Does it affect the structure or the function of the body? And is it associated with different symptoms and signs? So this is basically what the Commission tried to pull apart as we tried to think about what obesity is and whether or not obesity fulfills the conditions of a disease. Given that in some countries up to 45% of people are now living with obesity, and in most countries around the world, at least 70% of people are living with overweight, we wonder if it is an abnormal condition. And so you have to then look back into history and say, was this in prehistoric times the way that people lived? And historically, we're probably living in an abnormal time rather than obesity being a normal condition. But obesity does affect structures and functions, and we'll run through that a little bit, and it does have specific symptoms and signs. So if we go back to that pathway, etiological factors, we can identify very clear etiological factors for obesity. They can be genetic, they can be environmental, they can be hormonal, they can be epigenetic, and they can also be induced by the environment we live in, such as the medications that we prescribe people. These different conditions then lead to excess adiposity in the body, and that excess adiposity creates inflammation, endocrine changes, metabolic changes and mechanical changes that in turn change liver function. And that can be your liver, your pancreas, it can be your muscles, it can be your brain, it can be any number of organs in your body. That organ function then creates this disease called obesity that changes bodily function. So I guess I would fall into the school that I would contend that yes, obesity does fulfil the criteria for disease. And if you think about obesity, and this is a lovely diagram that came from the surgical clinics of North America a while ago, and I think we could add a lot more diseases onto it now. But if you think of the diseases that obesity affects, that creates within human beings, at the centre of them all is the fact that the person is living with obesity, and that then causes them to have a myriad of other symptoms and signs, which could be potentially these diseases, or you could call them interconnected diseases. And importantly, we know that if people lose weight, that they do improve these diseases. So I guess one of the tenets of obesity being the disease is that it sits at the centre of all these other potential diseases, and it's a modifiable factor. But the idea of obesity as a disease remains controversial. I think Phil Shower said yesterday, as far back as the 1940s, the AMA or the WHO was prepared to say obesity was a disease, but more recently the AMA has recognised obesity as a disease. The World Obesity Federation has a position statement saying obesity is a disease. But just as commonly we see opinions that saying obesity is not a disease, that in fact it is actually a risk factor. And I guess the reason they say this is they go back to this diagram of people living with obesity and the diseases that are associated with obesity, and they say these are the actual diseases, but sitting in the centre of it is obesity, but obesity is actually the risk factor for these diseases. It's not a risk per se. And I think this comes down to sometimes political or geopolitical ideas that if we define obesity as a disease, what does that mean for the environment? Does that mean that suddenly we have to start paying for a lot more obesity care? Does it mean that people might be able to claim in our country things on the National Disability Network, which is an insurance scheme which helps people doing it? So it's a very complex argument as to why people want to see either obesity in the centre as a disease or obesity as a risk factor. And it can sound very nuanced, and it is nuanced, and it remains very controversial. And I think it's something we'll try to unpick a little bit more in our panel discussion later today. But I think if we're about to move forward as a profession and helping people living with obesity, we need to be clear as healthcare professionals what we're doing. Are we treating the disease itself, or are we treating a risk factor? Because it does impact on what we might be able to offer down the track. I think further muddying the water is that there is this concept of health, and health means that you are completely physically, mentally and socially have a sense of well-being, and it's not merely the absence of disease or infirmity. And according to the WHO, health means the enjoyment of the highest attainable standard of health, and it's a fundamental right. So can we have a disease and also be healthy? So there is this concept that people living with obesity can be incredibly healthy, and they can be living their life to the fullest. And perhaps then defining them as having a disease may be deleterious for that group of people. So it's a very difficult area to unpick, and that's why the Commission really spent a lot of time thinking about this and trying to come up with rational and pragmatic ideas and definitions so that the profession can move forward. So in conclusion, when you ask, should we consider obesity as a disease, I guess it remains controversial. I personally believe it does fulfil the definition of disease, but I also recognise that it fulfils the definition of a risk factor. And I think the definition of health confounds the argument in another way that we have to listen to, and we have to be sensitive to people with lived experience that are living with obesity but also feel that they're healthy. I also question if we have got a clear pathway from normal to disease, and it involves etiological factors, it involves disease pathophysiological pathways that ultimately end up in a disease and a sense of illness. Should we consider it differently to other diseases? Because there are a number of other diseases where there's also a risk factor or a disease at the centre, and then other co-associated diseases, and that includes diabetes. Diabetes could be in the centre, and you can have vascular disease, heart disease, neuropathy, ulcers, any number of other diseases associated with the disease of diabetes in the centre. So is that a disease or a risk factor? Similarly with hypertension and either other diseases like scleroderma. And if we are going to consider obesity differently, then I'd like to ask why. And that's a question that I think we all would have a different answer to. But I'll leave you with that question. Why are we so reluctant to consider obesity as a disease? So thank you again very much for everyone for the opportunity to be part of this interesting session today. I'm now going to welcome to the podium Francesco Rubino, who's been the driving force behind this. And Francesco is now going to talk about the concept of obesity being ill-conceived. Thank you.
Thank you, Wendy. Thank you, everybody. I'll try as first show my disclosures and also the disclosure for the entire commission, which, as Priya said, did not receive any funding from industry. We only just logistical support from King's Health Partners, which is my institution, and I want to publicly thank for all the support throughout these years. As I put back the list of commissioners with the intent of showing to you the people behind this commission, you will recognize many colleagues, esteemed colleagues, leaders in the fields, and certainly many friends. And these are people who worked tirelessly for many, many months, actually for 2.5 years, from different parts of the globe. I cannot even imagine, because we had it easy in London, having these meetings at 1 o'clock in the afternoon. But my colleagues here in Australia or on the west coast of the United States had to actually connect at 5 a.m. or 1 or 2 a.m. And it's really, that attests to their commitment to the advancement of this field. So I really want to thank in particular those commissioners who had to make an extra effort to participate. Now, one other thing, as you continue to look at the names here, that I want to emphasize is that as we joined in these meetings and webinars every week, every month to discuss, it became immediately clear that this group had, like everybody else, like the rest of medicine, held a range of opinions on key aspects of the work we were trying to do. And at some point, somebody said, you guys are never going to be finding an agreement on anything at all. But in reality, the work that we did was to scrutinize each and every of those opinions. We didn't try to make a survey to see which one was the majority opinion, but more scrutinize the pros and cons on each individual opinion to see what was the reason why some people could not embrace one or another opinion. And it became very clear right away that on many things, including the concept of obesity as a disease, nobody was entirely right, and nobody was entirely wrong. So there was always some truth and some reasons why people supported certain opinions against or for obesity as a disease or other things. And that shows that if everybody has something right in their reasoning and something wrong as well, that there is something wrong with the framing, the whole framing of obesity. And in fact, The very reframing of obesity does not make allowance for the recognition of obesity as a disease. Obesity is defined as a condition of excess adiposity, which by itself is neutral from a health point of view. It's just a physical phenotype. But the health impact of obesity is described as a risk in this definition. So with that in mind, I want to remind you of this framework of risk versus issue, which is the way we conceptualize strategies to approach problems. And this is true in any industry, in any domain of human activities, including in medicine. Now, at risk is a condition where there is a hazard, let's say a hole that somebody could fall into as they walk, and the risk is the probability of falling into that hole, okay, so having a negative event. The probability will depend on a host of factors, of the speed of which we're walking, how far we are from that place, et cetera, et cetera. When you have an issue or a problem, the risk has already materialized. That's conceptually obvious. And so this is so important. And it's important to think about this because this affects everything we do, including in healthcare. And of course, when you have a situation of risk, you make contingency plans, hoping that that risk never materializes, but you also make interventions to prevent from falling in that situation. But once somebody is into the hole, the problem has occurred, you have to have somebody coming to help to dig this person out of the hole. And so obviously the interventions, the strategies that work at prevention will not work when the issue is materialized. And vice versa, using solutions that are good for solving a problem will not be good, suitable for prevention risk. And you can see this important framework not being clear in obesity because we conceptualize obesity as a risk. And so we tend to approach it with preventative, at best, measures and never really with proper solutions. So here's the difference between health risk and disease. A health risk is the likelihood that something will harm health. It's a possibility, but it's not happened yet. No matter how high that possibility is. A disease is a condition, it's a problem already occurring, ongoing, where the person's body is already harmed. And because one of its parts, in other words, organs, are unable to carry the usual work that they do on a daily basis. Now, there's fundamental differences between health risk and disease at many levels. But importantly, the way we approach conditions of risk in healthcare, in medicine, is by prophylactic interventions. Because the time horizon for the negative event to occur is away from us, is in the future. When you have a disease, you can only approach diseases with corrective or therapeutic interventions, because the horizon is no longer far from you, but it's here, in the present. It's here and now. And so this time horizon is important because it informs the decisions of everybody, of all stakeholders, from patients who might not feel the urge to approach obesity because they're told it's at risk. And of course, each of us has a different relationship with risk, how we feel compelled to address a problem or procrastinate, perhaps, and this is human nature. But doctors, too, approach risk and disease in different ways, let alone, of course, policymakers who have limited resources and budget, and when they have to make decisions, they have to have priorities and mechanisms to prioritize. So if they don't have budget for this year, they will think, okay, I will think about obesity in the next one. And this happens all the time, just because we framed obesity as a risk factor. So some people say, well, why don't we call it a disease and everything will change. We'll put everything in place, so finally things will work. So this approach of saying, okay, we need to call it a disease is called the utilitarian approach. We think that it will fix problems that we have in obesity, and because of this, it's a good thing to do. And this is how many organizations are approaching this. They're saying obesity is a disease, and if somebody doesn't listen, we're just going to say it louder. This approach, unfortunately, is set for failure, because as you put obesity, the disease question, as a matter of utilitarian, philosophical, pragmatic things, but not based on science and clinical evidence, then everything, all the other responses become equally legitimate at the level of ideology, political interest, and other forms of agenda. So it becomes a problem that is no longer medical. So this question is addressed by politicians. Have you ever seen a politician defining a disease or the diagnostic criteria of a disease? But we see them doing this all the time. So the medical profession abdicated in the very moment that we decided to define these things, not because of clinical evidence, but because of even well-intended utilitarian reasons. There is a problem also why obesity as a disease is not accepted, and the reason is because, in fact, it's a very heterogeneous condition. You may have people who have obesity by BMI and don't even have excess adiposity, which defines the condition in the first place. So people who are like athletes, etc., they don't have excess adiposity. If you were to call obesity a disease, even those people would be put into the group. But even when you look at excess adiposity itself, so people with confirmed excess adiposity, there is no question that this is also a very heterogeneous condition. There are people who have excess adiposity for all sorts of reasons. And some of these people may be healthy, and some of these people may actually have already an ongoing illness. So it's true that perhaps all of those who have excess adiposity have some level of risk, and this is variable according to ethnicity, age, and everything. But it's also true that many of them can maintain health for a long period of time. And a disease diagnosis is always at an individual level, and it's always here and now. You don't diagnose diseases if not when they occur. So we can't really propose obesity as a disease blanket definition. In fact, if you do, you create all sorts of paradoxes, including members of the public saying and pointing to us as a profession and saying, how can you justify the fact that we see people feeling healthy, being fully active and capable of living a full life, including winning Olympic medals at the latest Paris Olympics, and people with obesity saying, I feel I don't have a disease. We cannot put this evidence under the carpet. Any model we propose must be coherent and explain also what we call the paradoxes. The way we also frame the clinical impact of obesity has been, in a way, consistent with the definition of risk, but in another way, it works against us. Those mechanisms we have today, they work very well to score the risk of obesity. They were designed to score the risk of obesity, and they do this pretty well. They could be improved, but they serve us well in terms of scoring the risk of individuals, especially in regards to mortality. But intrinsically, these scoring systems include other diseases. You score the individual situation, health situations, with obesity-related diseases. There is no diseases in any textbook of medicine that is defined, let alone diagnosed, by the presence of another disease. That's just a contradiction. And so inevitably that doesn't help proposing why obesity is a disease, but also it cements the notion of risk as opposed to disease, and it encourages insurance bad practices, where they use this obesity plus criteria to define who gets the coverage of treatment, surgery, or medications, etc. And so you see time and again people who are sick by all means, with all symptoms of a chronic, ongoing illness, being denied access to surgery or drugs simply because they don't have diabetes, for instance. And this is a contradiction that unfortunately stems from the very framework that we have created. Now, the other thing is that you create a blanket definition of obesity. As I said, you put together a lot of things. It's a potpourri of things, conditions that don't belong to one another. Obesity can be just a physical phenotype. It could express a condition of risk. It could be an illness, but could also be a sign of another disease. So if you call it a disease is a single entity. Disease is one. And so you can't have many at the same time. So this is too much heterogeneous, and of course in the context of a condition so prevalent as obesity, it just makes any overdiagnosis, any level, even the lowest level of overdiagnosis and risk of overdiagnosis will create a problem that is bigger and bigger and becomes intractable. So the default response by policymakers is, I can't afford treating 2 billion people sometime in the next near future, so nobody gets anything at all. That's the inevitable solution. We need to give good explanations why this is a disease. And I'm going to just explain the Commission approach to this, because we ask what is a disease. Priya already explained to you that a disease is fundamentally, and also Wendy, is fundamentally characterized by the presence of an illness. The clinical manifestation of a disease must be present to show that there is ongoing disease. And this is typically the results of organs not functioning the way they should because of a pathophysiologic process, whatever it is. But make no mistake, there must be a specific pathophysiologic process and a specific set of clinical manifestations to characterize a single illness and with its own identity. You can't describe a disease for the presence of another one, just because each of them have their own process of pathophysiology, their own clinical manifestations. So the problem with obesity is that we're missing a piece, a fundamental piece. We don't have a description, we don't have a characterization, even if have known obesity for thousands of years perhaps, and hundreds of years, but certainly much more in the last few years. We don't have yet characterization of what is the illness that obesity causes. What does it look like? Do we know what diabetes looks like, what Crohn's disease looks like, what Parkinson's disease looks like? Everything we know, but we don't know exactly what obesity. We know obesity for the diseases that it causes. So here is a point I want to conclude with that it's very important. So clinical manifestations of a disease, the illness, represents the subjective and objective experience of the disease at individual level. There is no disease without illness, plain and simple. Diseases are fundamentally characterized by the ability to cause illness, and this is what gives identity to that disease. And this is what allows the clinical diagnosis, and this is what allows also differential diagnosis. So the Commission approach was to focus on this particular aspect. We know obesity can facilitate other diseases, fair enough, but we also want to see if obesity can induce its own illness, induced by obesity alone, without the help of other things. Obesity doesn't need diabetes to cause illness. That's the concept. If this is true, it should look like diseases in other areas, illnesses in other areas of medicine, so alteration of organ function. And in fact, the diagnosis is going to look, we cannot disclose the criteria, it's going to look similar to the diagnosis of any other chronic disease, which is quintessentially clinical in most instances, with only few notable exceptions, which we can discuss later. And I want to finish by saying that this new framework that we propose recognizes that obesity as a phenotype, excess adiposity, occurs on a continuum of increased risk to health. But health and illness are dichotomous conditions. And we do this all the time as clinicians. We have to make a certificate. If a person has a disease or not, we have to put ink on a paper and say if it's the case. We can't be too nuanced there. This is very pragmatic for all sorts of reasons. In other words, a clinical diagnosis corresponds to that process that I told you at the beginning about, the difference between risk and issue, whereas illness is the issue, indeed. And this is important to inform decision making, because when you understand that obesity can occur as a spectrum, but at some point can become an illness, then you understand where you have to, what is the target for monitoring and prophylactic intervention, which is this obesity, the risk factor, and what is the target for therapeutic intervention, which is obesity, the illness. And I hope we will be able to soon provide all the details through a publication, and fingers crossed it will happen very soon. Thank you. Hello, so it's my pleasure to introduce John Dixon. Also, John doesn't need introduction, especially in this country, but all over the world. And John has been a member of the Commission and will discuss the pathophysiology of clinical obesity.
Thank you, and again, welcome to Melbourne. I hope you enjoy your time here, and it's a real pleasure to have been invited onto this commission. Yes, the late nights were a struggle, but it was so fascinating to go through the process. I'm going to talk about pathophysiology of obesity and how obesity itself can generate problems. These are my disclosures. And these are of course, no industry funding related to the process. So, excess body fat, no ongoing illness. There's a pathophysiology, but these people would be considered healthy. Excess body fat with ongoing illness, we have signs, symptoms, alteration of day-to-day activity, complications. And there's a broad range of these. So as you've already seen, in other diseases we have the process of disease, pathophysiology, illness, and our problem is to define the illness associated with obesity. And you've seen this slide from Francesco. What are those ones that are down there that we really can nail as being obesity related? So first of all, we see that it's an illness, a condition that's going to affect tissues, it's going to affect organs, and it's going to affect the organism. And I think it's really important to think of the whole person, because there are so many people who have so many elements related to obesity, so many risk factors, if you like, but their life is really altered dramatically, their quality of life. So I know you've seen these, but I think chronic illness, alterations of function, and I want to emphasise that second one, interference with quality of life and age adjusted. Now, the word comorbidities is used by you people all the time, and comorbidities are conditions that we see as unrelated to obesity, excess fat, etc. It's important because when we talk about comorbidities in any other area, we're talking about things unrelated. There are complications of diabetes, there are complications of atherosclerosis, there are complications of all sorts of diseases, but we isolate obesity and call its associated complications comorbidities. Obesity-related disorders are those having overlapping pathophysiology, diabetes, not fatty liver disease, metabolic-associated steatic liver disease, etc., sleep apnea, the list goes on. They're associated. And complications of obesity are when serious things, serious life-threatening things happen, severe organ dysfunction, life-altering situations, etc. So it's important to get our language right, because if we don't have the language right, we can often go down that pathway where we ourselves are describing obesity as something that's not important. So clinical diagnosis, as Francesco said, we want anthropometric measures, we want evidence of excess fat, and we want reduced organ function, tissue dysfunction, etc. And when it comes to quality of life, it's age-adjusted limitations. Okay, so when we look at this list of issues and problems that we have, we sometimes think, well, it's overwhelming, but I want to just break it down to a few simple things. The first one I'm going to do is mechanical pressure and obstruction. Mechanical pressure and obstruction. Now think about this. The intra-abdominal pressure can actually it can be associated with raised intracranial pressure and benign, supposedly benign intracranial hypertension that occurs in generally premenopausal women, particularly adolescent girls and young women. Common? No, but it's very specifically related largely to obesity. The intra-abdominal pressure has an effect on the diaphragm and compresses the lung, and it reduces the compliance. It reduces dramatically the functional residual capacity. Now that increases the work of breathing. Pushing the lung up actually increases the obstruction of medium-sized airways, and you can imagine that you watch people we're living with obesity, breathless. Breathless, not due to asthma, not due to other things, but if they have other things, it's even worse. So there's a whole respiratory angle to this that we often don't recognise. When we look at the impaired venous return, again related to that intra-abdominal fat and so forth, and we see the issues of reduced compliance, intra-abdominal veins, which has its own story. But when we go to the legs, we've got lymphedema, we've got lipedema, we've got bronzed ulceration, we've got etc. So we have a whole process that's directly related to pressure. And when we go to direct pressure, we know about gastroesophageal reflux, we know about weight-bearing joints, particularly weight-bearing joints, where osteoarthritis is a problem. Skin-on-skin pressure. Now, we don't have any other thing necessary. Under the breasts, under the abdomen, between the legs, groin, and when the thigh is meeting in the middle and causing trouble. These are really critical things. It's important to recognise that those skin complications are really, really significant for people. Reduced joint mobility. If you've got a large leg, it doesn't matter what the joint's like, you can't move it in a way that is appropriate. You see people, even healthy people, with restricted movements. When we look at physical function, and the other aspect that we sometimes miss is that people living with obesity, they often have pressure neuropathy, and there's other reasons why they have neuropathy. So pressure is there, and it's directly related to obesity. I'll just go back, I think I went too far. Now we've got another area, and that is the visceral and ectopic fat producing cardiometabolic inflammatory disease, and we go through a disordered. Now, this is actually the symptoms of obesity directly, and I call it disordered eating. Other people would call it obesity symptoms, but there's hunger. There's always ready to eat, never satisfied, feeling out of control, persistent food noise, attention to food, and our patients have this. You know, so often they don't recognise this until they've been treated, till they've had surgery or had a drug that's effective, and suddenly these things decrease.
John, just apologies for 1 second. I'm seeing a lot of pictures, and of course I understand the interest for this, but please can I beg not to tweet this particular slides or any other major slides there, because obviously this is unpublished material, so please don't tweet, don't share on Instagrams or other things, please. Thanks.
Yeah, most important, what I'm saying is not I'm not talking about the results of So when we look at these, the excessive daytime sleepiness, you know, many of you would think that the excessive daytime sleepiness is associated with obstructive sleep apnea. And Epworth Sleepiness Score is a score that was developed here in Melbourne at a sleep physician at the Epworth Hospital. Epworth Sleepiness Score is that tendency to go off to sleep during various aspects of daily living. We found, and most of others have found, that there's no relationship between obstructive sleep apnea, the apnea-hypopnea index, and sleepiness. Our people living with obesity have this sleepiness, and it improves dramatically. But you can see there's other sleep disturbance. There's obesity-related hyperventilation, there's insomnia, there's restless leg syndrome, there's periodic limb movements. Shift workers more likely to get, the clock's out of whack, they're more likely to develop obesity. There are so many areas: cognitive domains, depression. There are interactions with depression, bidirectional, and of course weight stigma. And that is, weight stigma is experienced more by people as you get higher and higher weight. When it comes to ectopic fat and the true, what we see as the true metabolic issues that we focus on, such as the ectopic fat in the liver, muscle, pancreas, and epicardial, cardiac, and everywhere else, kidney as well, we see that ectopic fat is some of the most dangerous fat. We used to think it was visceral fat, and of course visceral fat is a marker for that, and so forth. So insulin resistance develops in muscle, liver, pancreas, and then there's systemic hyperinsulinemia, which has other effects. And then we have local and systemic inflammation. I see people who go on a drug, one of these new ones, and they lose a lot of weight, and the CRP falls. And I'm thinking, Do we believe this? Okay, so when I want to move to, so inflammation, this area is the one we really know about and causes so much cardiometabolic inflammatory risk. And this is one of my last slides. This is a slide I prepared many years ago, and I kept adding to it as things happened, but obesity-related illness, very much metabolic inflammatory cascade associated with those physical problems, deriving a whole lot of what I call a cascade of issues, driving a range of mental, physical and metabolic disease. So finally, a pragmatic approach to defining obesity, defining illness due to obesity, I don't think is that hard. Now, if we look at tissue, we look at organs, we look at the organism, we can do that. Finally, I want to make one thing, make a single point. Risk factors driving health costs in Finland, UK and the Netherlands. A randomised, a Mendelian randomisation study, because these people have biobanks and allows us to look at causality. So what are the risk factors that cost health services in Finland and UK and the Netherlands most? What are the risk factors? There they are. Number 1, waist circumference. Number 2, BMI, closely followed by systolic blood pressure. And the rest? If you don't think obesity, the disease, is generating costs in our health services now, there it is. So we must act, and we must have our patients considered. We're paying already, clearly. Thank you.
Thank you very much, John. The next speaker is Professor Louise Baur. Louise is the immediate past president, I think, of the World Obesity Federation, and is a paediatrician from Sydney, professor with the chair of Child and Adolescent Health. And Louise is going to talk to us about how we define obesity and the implications for clinical practice.
Thank you. Thank you to Wendy and Francesco, and it has been a real pleasure to be part of the Lancet Commission. And I'm coming as a physician, as an internal medicine specialist, particularly a paediatric one, but I'm going to try and do service to the whole of our thinking about this. These are my disclosures, personal ones, not relevant particularly to the Lancet Commission. I want to start by thinking about implications for clinical assessment of people. Here we see these schema that we've seen before. People ask me, can I still use BMI to assess a person with obesity? Does it measure body fatness and risk? We've also already seen that just because a person is bigger doesn't mean that they have high fat mass. We can see this person on the left. And even those people who have a high fat mass may have different levels or even absence of ongoing illness. Nevertheless, as a screening tool, BMI is still useful. It's got pretty good sensitivity and specificity, but it's a screening tool. However, as we've already heard, there are limitations to the blanket use of BMI to denote obesity, and this has been what has tended to be the case in the last decades. I think it's where assessment starts. It's actually not where it finishes. It's part of an assessment. It's really important in terms of anthropometry to supplement BMI with some measure of fat distribution, such as waist or waist to height ratio, or if you have it available, something such as dual energy X-ray absorptiometry or some other well-validated measure of body composition, knowing that some of the quick and dirty ones that people may use may not be well validated in people of high fat mass. As a paediatrician, I just encourage you to use well-validated and age and gender and ethnicity appropriate cut-off points in thinking through these issues. But what about other forms of assessment? And I want to just highlight it's really, really, really important to take a history, to examine a patient and to investigate as required. We learnt this through med school. I'm sure all of you who are other forms of clinicians understand the importance of history, examination and appropriate investigations. And the new clinical obesity criteria will clarify this further. The questions we're asking is, what other health problems does your patient have? What distinguishes the person who just has a high BMI, a high body fat, from the person with clinical obesity who has health problems? What are the different clinical approaches for these two people? Now, we've already seen this as well. We're reinforcing messages throughout our talks here today. But the concept I hear, so you have people with excess body fat with no ongoing illness and people with excess body fat with ongoing illness. And you have different pathophysiology over that course. You have different clinical manifestations, and the way you diagnose will be somewhat different. You'll have more intensive investigations if you suspect the person is on that right-hand side. Let me just think about implications for treatment. Again, we're reinforcing messages we've already given. You have this woman here on the left-hand side who has preserved health. And with her, who she presents to you, you may reflect upon monitoring. You may look at, in consultation with her, about prophylactic intervention and risk reduction. With the person on the right-hand side who has illness, you'll be thinking about, in consultation with the patient, about a therapeutic intervention, about disease treatment. For those with obesity and ongoing illness, they require timely access to comprehensive care and evidence-based treatments and individualised decision-making. You know this already. And the goals of therapy will be to improve or to help the remission of clinical manifestations of obesity, or to prevent the progression to further complications or end organ damage. And the different clinical manifestations of obesity may require different intensities of treatment and or weight reduction. Earlier this week, in our clinic at the Kids Hospital, I saw a newly fast-tracked patient, a teenage girl with newly diagnosed raised intracranial pressure, who had bilateral papilledema and who had blurred vision. Now, of course, the neurologists and the ophthalmologists were the most important people in terms of treating her, but our team was actually being involved in putting her onto a very low energy diet and giving her very, very strong support over the next few weeks in order to get some more rapid weight loss also occurring. That would be different approach from some other people. That's a more severe manifestation of this problem. Here, clinical care has a corrective intent. And of course, as we've seen before, another slide that we've seen throughout this week is that there's different types of therapy available, each variably helping different people, but we can see different types of pharmacotherapy, we can see behavioural support, surgery and so on. And all of these are important, and what we know, and we've been hearing it throughout the week as well, is that there is a need for better understanding personalised treatment pathways, including the use of combinations of different therapies or different therapies at different times. That's not our focus here today, but I just want to say this is also part of the way that we need to think about how we approach clinical obesity. But what about those people with high BMI but no or minimal associated health problems? As we've heard before, they have a variable level of fairly low health risk, but with substantially preserved health at present, and that's fantastic. And such people require individual risk and benefit assessment based upon the severity of excess or abnormal adiposity, or the presence or absence of other risk factors and coexisting diseases or disorders that will benefit from specific treatment. And this here, the focus in treatment is to aim at risk reduction. So for those with a low risk for health problems, health counselling and reassurance may be most appropriate. But those with higher risk, other interventions may be appropriate. So they may benefit from pharmacotherapy or possibly even surgery, but it generally requires less urgency and intensity of care than in those with clinical obesity. These are some of the nuances. I want to give you 2 adolescent case examples. Both of them will be 14-year-old boys with a BMI of 39.9, waist-to-height ratio of 0.7, so high waist-to-height ratio. The first lad is of Maori ethnic origin. He has a strong family history of obesity and type 2 diabetes. There's no evidence, certainly as yet, of cardiometabolic risk or obstructive sleep apnea. He has got good mental health, a great friendship group, no experience of bullying. He loves rugby training and games. He wants to keep up with my mates on the rugby field, but knows he is not fit enough. I wonder whether I should even treat him, because I asked him the important question, if New Zealand's playing Australia, who do you support? And he had to have the right answer. No, it's not right. I don't do that. So the treatment approach for him is to engage this young person and family with the multidisciplinary team. That's, of course, always important. This lad will really benefit from an exercise scientist assessment with a gym and training program given, and we liaised with the coach. He needs frequent dietetic review with the aim of helping him to be match fit. That's how we talked about it. And also to decrease his longer-term risk of type 2 diabetes. He wasn't worried about that, but his mum was. And he opted, at least initially, for an intermittent energy restriction plan. Okay, this is a risk reduction approach. What about the next lad? Exactly the same anthropometry. He's of Anglo-Australian ethnic origin. He's also got a strong family history of type 2 diabetes and obesity, and his mum's had sleeve gastrectomy. He has obstructive sleep apnea, and he's on CPAP, but he's very, very variably adherent. He has some depression, he's experienced a lot of bullying at school, he has some school refusal as a result. He's immersed in screens and gaming. He has acanthosis nigricans, he's limping. He has abnormal liver function, he has dyslipidemia, but he doesn't have diabetes, and he's complaining of joint pains. So again, our treatment approach, we engaged the young person and family with a multidisciplinary team. Now, I'm sorry for the acronym, he has slipped capital femoral epiphysis, so significant complication associated with obesity, so he's actually basically in this growing joint. He's got his hip slipping apart, that's a very physicianally non-orthopaedic concept, and he was referred for urgent assessment by the orthopaedic team, had surgery and needed to have rehabilitation to increase his mobility. We provided clinical psychology review and support for his depression. We liaised with the school about the school refusal. We were liaised with the other clinical teams. He had frequent dietetic review. He was commenced on semaglutide, which was off-label, provided by the hospital, and he may be a candidate for metabolic bariatric surgery in the future. Same anthropometry, very different clinical approaches. Now, I know you would have worked that out anyway through normal assessment. This was a corrective approach. So if we go back to that, we've seen this before, the idea of this continuum between risk to health and illness, where down one end we're looking at weight loss, and at the other we're looking at improvement and remission of clinical manifestations and preventing complications or end organ disease. In summary, I just want to highlight that people with confirmed excess obesity should be assessed for health problems to rule out clinical obesity. I think you're already doing that. The goals of treatment to improve or help the remission of the clinical manifestations of obesity and prevent progression to further complications. And the intervention principles are to require an individual risk-benefit assessment, and it should aim to improve clinical manifestations of obesity and quality of life, or reduce risk of disease progression or even mortality. Thank you.
Thank you, Louise. And the next speaker, before we proceed with a panel discussion, so I invite the other panelists to come closer for the next session. But meanwhile, I want to introduce Dr. Ricardo Cohen. Also, he doesn't need an introduction. He's the president-elect of this organization. He's from São Paulo, Brazil, as a member of the commission and a good friend.
Thank you, Francesco. Good morning, everyone. I'm very happy to be here, and I'm very happy to be part of this commission. Those are my disclosures, none of them related to this presentation. And the other disclosure is I am part of the co-writing committee of the Lancet Commission paper. So it was a huge work in the past 3 years, almost 2.5 years. So in a different way to show this is obesity as a disease. And we have different complications of one disease. And currently, this is important to us, surgeons. We're not treating anybody. We're treating 1% to 3% of people that are eligible for surgery. In an optimistic way, less than 10% are undergoing pharmacological therapy. We still have 20 to 30% of non-responders in both alternatives. And we have a problem because the current framing of obesity, as was presented by the previous speakers, has a prophylactic intent because obesity is defined as a risk factor that can avoid the progression of the complications. And we have the so-called comorbidities. And we've been preaching the same time for decades ago. I am a marathon runner, so I'm persistent. And I make a lot of efforts to go to the finish line. But we make a lot of efforts to make metabolic surgery great again. But we're not successful. We've been speaking over that we have wonders after metabolic and bariatric surgery. Because we're very open to quackery. I don't know any other specialty or treatment that will allow this. Oral tirzepatide. Weight loss, fasting diet, in 5 days you're going to lose 20 kilograms. And as presented by the previous speakers as well, there's a huge misconception between prevention and treatment. We know that lifestyle interventions are very good for preventing obesity, but they're completely different than treatment, surgical or pharmacological, and they both work together. There's a big scientific bias. Nobody cares about the SOS with 20 years after a gastric bypass delivering 25% of total body weight loss. Not too many people care that we have, those are listed, the papers that have at least 2 years follow-up, randomized control trials, at least 2 years of follow-up regarding glucose-centric endpoints. We don't care. They don't care. We compare the guidelines, 1991 and 2022 IFSO ASMBS guidelines. And in a very recent paper published at Obesity Surgery, 90% of the primary care physicians in the US were unaware of the guidelines. So we have guidelines and nobody reads them. So why we pay so much attention and efforts to guidelines? Again, this is Jack that Francesco showed. Jack has all of the complications, signs, and symptoms of obesity. However, if he had diabetes, he would grant access to medication. But he doesn't have diabetes. So we need another disease to define another disease. And this is quite unacceptable. So what would make a difference regarding reframing obesity as a disease state in clinical practice? A disease, as shown previously, has a negative impact on health at the present, right now. While, look at the definition of obesity. It's an abnormal or excessive fat accumulation that presents a risk to health. A risk to health may be present or not, as mentioned before as well. Two surgical examples. If we have a thyroid nodule, we won't go to a thyroidectomy regardless. There's a lump there, I'll remove the thyroid. It would be easy. If I had Barrett's esophagus, I would perform an esophagectomy to those patients because they have a Barrett's esophagus. We would follow them up and see which is the appropriate therapy during that follow-up in individual patients. This is again on BMI, and BMI really is a great tool for epidemiologists for screening purposes, but often misleading at the office, as shown by Louise, because it denies access to obesity treatments, anyone. Because it's unigender, it doesn't differentiate between genders. It doesn't allow the evaluation of the fitness status. Mike Tyson, at his peak, had a BMI of 37. I don't think he was eligible to drugs or surgery. And it discriminates against older patients and different ethnicities. So BMI should not be used to diagnose clinical obesity, by itself, by its own, rank the severity of obesity. It's only a measure of height and weight. Should not be the sole criterion to establish indications for any therapeutic interventions, mainly metabolic surgery. And it should not determine the coverage for obesity treatments. So if we wear the shoes of payers, policymakers, public health professionals, the public, what should we do? I would be scared to have 2 billion people to treat because this is unaffordable. This is really unaffordable. So, to avoid overlapping all the previous speakers, what the Lancet Commission on Clinical Obesity may interfere in our clinical practice as metabolic surgeons. First, it will decrease the stigmatization of obesity itself because we're defining a disease by its own with its own signs and symptoms, and will decrease the stigmatization of metabolic surgery because most people still think that metabolic surgery has a prophylactic intent and is cosmetic. In this audience, of course, we don't think so. However, if we look at the lay public, they still think there is a cosmetic purpose. If we prioritize who needs treatment first, so we can grant access to those who need most first, that doesn't mean that the others will not be treated. They'll be followed, surveilled, and eventually treated when the disease presents, when they fall into the hole, as Francesco presented. We have a different measure and way to report remission of clinical obesity. Because yes, we can define remission of diabetes. It's measurable through A1C, fasting plasma glucose. We can define a remission of a kidney failure. If you got cystatin C greater than 1, if you have your albuminuria below 30, we can define remission of diseases. But we cannot define remission of obesity because we don't have a definition of obesity itself as a disease. Then we can grant payers, policymakers, public health specialists, previsibility who needs treatment first. So if you do not scare who owns the money, they'll think differently about the approaches to treat obesity, especially in our field, metabolic and bariatric surgery. And finally, I think we're going to have more demand for metabolic and bariatric surgery, exactly because we're defining obesity as a disease itself that deserves treatment in a prioritized way. Thank you very much.